The lacrimal apparatus is a functionally important physiological system in maintaining the tear dynamics. Lacrimal puncta play a pivotal role in the drainage of the tears produced by the lacrimal gland. In this video, we discuss and illustrate various lacrimal punctal abnormalities and their management. Lacrimal puncta are small orifices situated on the summit of an elevation called the papilla lacrimalis that lies near the medial end of the eyelid margins at the junction of its ciliated and non-ciliated portion. Puncta are surrounded by a ring of dense fibrous tissue which keeps them patent. Lacrimal canaliculi connect the puncta to the lacrimal sac. The vertical part of the canaliculus is about 2 mm. It joins the 8 mm long horizontal part by an ampulla. The disorders of the puncta can be isolated or seen in association with canalicular or nasolacrimal duct anomalies. The development of the lacrimal system begins embryologically at stage 16, the lacrimal lamina stage, followed by the lacrimal cord stage, excretory lacrimal system differentiation, and maturation. The lacrimal canaliculi begin at 12 weeks of gestation and become patent during the 4th month of gestation. The puncta open onto papilla just before the eyelid separation at 7 months of gestation. Disturbance at any of these stages leads to the developmental punctal anomalies. Histologically, the walls of the canaliculi are lined by stratified squamous epithelium. Surrounding it is the corium, which is rich in elastic tissue and makes its wall so stretchable that it can be dilated to about 2 mm. Fibers of the orbicularis, which surround the corium of the canaliculus, are called pars lacrimalis. These help to draw the eyelid inwards, thus allowing the punctum to glide in the groove between the plica semilunaris and the eyeball. Punctal anomalies can be broadly classified into primary and secondary. Primary punctal disorders include punctal agenesis, incomplete punctal canalization, punctal stenosis, supernumerary puncta, and ectopic punctum. The secondary disorders include peripunctal disorders, punctal trauma, punctal ectropion, iatrogenic punctal disorders, and contiguous punctal involvement in systemic disorders. We briefly discuss a few of them in the video. The most common clinical presentation is epiphora. It can be graded as follows. Fluorescent dye disappearance test is a simple diagnostic test to grade the severity, which is classified from grade 1 to grade 3. Examination of the puncta includes site, size, shape, position, peripunctal tissue, and adjoining area. Punctal agenesis is the absence of the lacrimal punctum secondary to a failure of embryogenesis. It can be unilateral or bilateral and can be found in association with canalicular agenesis and nasolacrimal obstruction. Various ocular and systemic associations are seen with punctal agenesis. On examination, there is an absence of the punctal papilla, pars lacrimalis, or even a transilluminant membrane. Occasionally, eyelashes are found medial to the expected punctal location. Dacryocystography and OCT imaging can give us an idea about the canalicular patency. The management depends on the symptoms and the extent of the obstruction. No intervention is needed in asymptomatic patients. Decapitation and creation of a neopunctum. Canalicular marsupialization in cases with concurrent proximal canalicular obstruction. Jones retrograde probing. Canalicular microrefination with lacrimal stents. Conjunctivodactylocystorhinostomy with Jones tube are other options. Incomplete punctal canalization is punctal dysgenesis with membranes. It can either be external, where a membrane covers the external surface, or internal, where a translucent membrane is present at the punctal entry with blurred punctal margins. Membranotomy with a punctal dilator is successful in management of this condition. Punctal stenosis is narrowing or occlusion of punctal caliber, which is classically defined as less than 0.3 mm or inability to intubate the punctum with a 26 gauge cannula without dilation. The stenosis can be congenital or secondary to infections, inflammation, surgery, systemic diseases, mechanical or iatrogenic. Punctal stenosis is classified as shown here. Chronic inflammation of the external punctum leads to gradual fibrotic changes in the ostium, followed by progressive occlusion of the duct. Based on the shape of the external punctum, punctal stenosis is of 4 types: membranous, slit, horseshoe, or pinpoint. Few more shapes have been described by the OCT. There are several treatment options available for punctal stenosis. The basic principle is to create a patent punctal opening and improve the drainage of tears while maintaining the function of the lacrimal pump. Punctoplasty is the most commonly done procedure and has evolved over the years. A vertical incision along the ampulla is given in one snip punctoplasty. 2 vertical cuts each in the medial and the lateral wall are given with excision of the flap in 2 snip punctoplasty. In 3 snip punctoplasty, as demonstrated here, puncta is dilated with a nettle-shaped punctal dilator. The first vertical incision is made down the ampulla. Second horizontal incision is made along the vertical part of the canaliculus. The last incision is made along the base of the free flap opposing the bulbar conjunctiva that creates a triangular shaped broadened punctum. A rectangular modification of the last step has also been described. Adjuvant mitomycin C can be used in cases of excess peripunctal fibrosis. Supernumerary puncta are rare and result from the multiple epithelial buds developing from the upper end of the lacrimal cord. Patients are usually asymptomatic and can be conservatively managed. Punctal anomalies, when examined methodically and managed appropriately, gives gratifying outcomes and patient satisfaction.